medicine.
Yes,
And
good morning, everyone. Good morning to Grand Rounds. I'm really excited. I was so excited, Russ, when I saw your name come up. My fellow Texan, my fellow endoscopist, my fellow person that's a go-to for colorectal surgery. I see Juliana Brown on now. She probably wants to say a few reasons why she wanted to have someone who is from the Department of Surgery talk at our medicine grand rounds. And I'm not going to steal her thunder because I see her there ready to talk. But good morning, everybody. Juliana, you're on.
Good morning. Yes, thank you, everyone. Thank you, Dr. Kruger. So it's my pleasure as the Internal Medicine Clerkship Director from the Division of General Internal Medicine to introduce Dr. Russell Farmer. He's going to be talking about colon cancer screening. No, I'm just kidding. This is about medical student education. Dr. Farmer attended medical school at the University of Texas Health Science Center in Houston. He's done his surgical training, including residency and colorectal surgery fellowship here at University of Louisville. He's been on faculty within the Department of Surgery since 2015. But kind of the main reason why he's here with us today is because he's been the Assistant Dean for Medical Education, specifically clinical skills, since about a year now. And Dr. Farmer really has demonstrated how deeply he cares about our students' education and evaluation and just making their experience better. And so for us in the Department of Medicine, in this academic year, we'll have approximately 166 third-year students rotate with us, plus another 60 or so that are because they got disrupted from COVID. We've got about 30 acting interns. We'll accommodate at least 60 people through our MOOC, and that's not including, any of the subspecialty electives. So we, in the Department of Medicine, do a lot of medical student education, and it absolutely wouldn't work without faculty, fellows, residents. We really appreciate your time and your work with the students. So Dr. Farmer today is going to give us an update on medical student education that hopefully we'll take forward and use throughout the academic year. So, Dr. Farmer.
Hey, thank you. Good morning, everybody. Let me get my stuff up and rocking here with this screen sharing business. So here we go. 1, 2, skidoo. Okay. No, we have to start at the beginning. Okay. All right. So this will be a little bit difficult because I can't see the chat, but maybe Tim and Jason, y'all can help me out. So first off, I'm Russ Farmer. I do all those things that Chris and Juliana said, but my primary role here, in addition to serving as essentially a colorectal surgical oncologist, I primarily focus on colon and rectal cancer, and I also do a lot of inflammatory bowel disease and motility work. So one of the other hats I wear primarily is helping teach medical students, and so in so doing, I'm going to try to give you guys some tips and tricks around that so that we can all be better educators for our students, and the students can be better educators for themselves. So I will do my very best not to go over time, but we got a lot to get through. So I would start by asking in the chat or, chat's going to be better because we have 70 plus groups of people logged in right now. Write down an example or two of a question you might ask of a learner. So I got to figure out how I can see the chat window on this thing. Maybe if I alt tab, maybe that'll work. Yeah, I can alt tab. That's how we're going to do it. So you will learn as we go through this talk that I have infinite patience when I'm asking a question. So if I'm asking y'all to write down a question you might ask of a learner, if no one writes down a question, we will sit here for 60 minutes. I do not care. Because one of the most critical things that you can do in asking a learner how to, a clinical question is to give them the time to answer. We know from having studied this that the median time given of a student and a resident to answer a question asked to them by a faculty member is somewhere between 2 to 3 seconds. And I don't know about y'all, but my neurons ain't working so well these days. And so 2 to 3 seconds is not going to be enough time for all the satellites to link up and the neurons to speak to each other. Okay, so we got a few. What conditions might present this way? What's your differential diagnosis? What else do you think this could be? Okay, so those are some good examples. Frank says, how would you interpret this? Okay, so I have a couple things we need to talk about in terms of disclosure. First off, I was originally planning on talking about LCME and the upcoming site visit, but that was out of confusion on my part from what Juliana was asking me to talk about. So those topics are much better covered by my partner in crime and lead educational dean for the medical school, Dr. Ann Shaw, who's also a member of your clinical faculty, so I will leave that up to her. We're going to be talking about actual teaching strategies and abilities as opposed to the day-to-day in and outs of getting ready for an LCME site visit. So that's the first thing. I apologize if my video is not the best or my audio goes in and out. I'm on the Wi-Fi at the HCOC, and I would imagine that a lot of you know that that's a bit spotty. So I'm also going to apologize to my good friend and dear colleague, Dr. Laura Bishop, for the quality of the slides and the presentation, because she's my design guru and all-around buddy. And if these slides are not up to your snuff, Laura, I'm very sorry. I'll also make one last disclosure that these are very, very weird times, and so I'm not used to giving grand rounds to a green dot next to my webcam, so I'll do my best. With that being said, I have one last disclosure. When I think of for the physician workforce, I think of something that looks like what you see on the screen. But in the past 6-8 months, when I think of the physician workforce, this is what actually shows up in my mind, because I don't know about y'all, but this is where I'm at. Hopefully I started out like the last slide, the paragon of, medical knowledge and education and thoughtfulness and empathy toward my patients and everything else like that. But we've ended up like Bunsen Honeydew's esteemed colleague Beaker. Some days I'm doing real good if all I can manage is to actually look at my patients and say, meep, because that's about all I got coming out of me these days. But we're going to try anyway. So with that being said, let's get into the meat of the talk. So we're going to talk about strategic questioning and the clinical learning environment. So what is strategic questioning? How can it help us teach our students and our residents, and how can we practice it? And there's a couple different things to that, and we actually have some, once we get them off the printer, we will get to you some handy-dandy teaching aids, and hopefully coming to a smartphone near you very soon. So as an educator, I'm going to have learning objectives. I learned this from Dr. Shaw as well, that you can't have a good lecture or talk without giving some learning objectives so people know what they're supposed to be learning. So we want you at the end of this to be able to utilize Bloom's Taxonomy as a tool to help learners develop clinical reasoning and critical thinking skills. We hope to help you learn to create questions for your learners using Bloom's and some questioning strategies and different, what we're going to term Bloom's verbs. And we want you to revise the type of questions that you're asking your learners on a day-to-day basis as you're rounding on your patients to help improve some critical thinking skills. So notice that these words here are underlined, and the reason that they're underlined I'll get to in a minute, but remember, utilize, create, and revise as we go on. So I'm going to ask everybody a question, and you don't have to answer this out loud, but this is the question that I ask almost everybody when I give any sort of talk, and that is, who are you? And I want you to take, you don't have to answer it out loud, you don't have to type in the chat, but maybe take a few seconds and think about the answer to this question. When I answer this question, I think about, doctor, I'm a surgeon, I'm a father, I'm a husband, I'm Jewish, white, I'm no doubt way overprivileged. I'm from Kentucky now. I've been here for 14 years, so I guess I have to say I'm from Kentucky. So, but think about, who are you? Okay. So I would suspect that a lot of people, and hopefully our medical students, as they develop their professional identities, answer this question the same way, which is that I'm a doctor, right? You'd say I'm a doctor and I take care of people, right? That's my job. And notice I didn't say physician. And the reason I didn't say physician is because a physician is someone that takes care of the health of someone else, but a doctor has a much more noble lineage and heritage. The word doctor dates back to not the old, but actually the ancient Proto-French, coming from Greek, the word docere. And if you can pronounce that in Greek, you're better than I can. I can't. But the Proto-French word doctere, which did not mean to take care of people. It did not mean anything having to do with human health at all. It meant to teach. And not only did it mean to teach, it was the original intent behind it was to teach the best way, or to demonstrate the best way to do something. Up until the Flexner Report, to become a doctor, all you had to do was walk out and say, "Hi, I'm a doctor." Put a barber pole outside the front of your hair salon in the saloon and offer surgical services. In my case, or if you were like my great grandfather, you were a frontier doctor. You hopped in the back of your cart and you traveled all over West Texas, trading health care for chickens. And the occasional goat if he could get one. That's like, delivering a baby gets a goat, just cold and flu gets a chicken. So at its core, a significant amount of healthcare is teaching. And if you think about it, there is a lot of validity to this because you are serving as the ultimate expert to your patients. You're teaching them about their body, about their diagnoses, about the medicines that they need to take when they need to take them. I mean, you are an anatomic and physiologic instructor of everybody around you all the time. And to link those concepts together, the concept of healthcare treatment and the concept of teaching, I think naturally goes hand in hand. So how many of you all answered the question this way? How many of you thought to yourself, I'm a teacher? I teach myself, I teach medical students, I teach residents, I teach my colleagues, I teach my nursing staff, my pharmacy staff. How many of you looked at this and thought to yourself, this is one of my major identifiers? You notice I didn't say this the first thing out the gate either. But when you stop and think about it, because you are surrounded all day by multiple different groups of learners, this is one of your primary roles, is to serve as a teacher to the young people all around us. And it really does magnify your impact when you think about it, because if you can teach even one medical student about the nature of healthcare, how to provide it, how to care for others, by doing so, you're not just caring for one patient, you're caring for thousands of patients, thousands of them over the course of an entire career. We do that through professional modeling and demonstration, but really the thing that we're trying to teach as we do this is what we call critical thinking. And critical thinking comes from any number of things, but really what critical thinking comes from is connected knowledge. And so connected knowledge is, I'll give you an example, is being able to take two different packets of information and link them together in an almost subcortical way. So when someone has mastery over a piece of knowledge, they are able to look at that piece of knowledge and access that as a whole block and then bring that to bear. So let's say, for example, my colon and rectal fellows that I have every year, in an ideal world, by the end of that fellowship, they wouldn't look at the operation that we're doing as first step, second step, third step. I mean, they'll need to know that, but ultimately they're going to pull that whole operation out and bring it forth and put it down and do that operation while they're also thoughtful of long-term decision making, right? Should we put this patient's colon back together? If we do and it leaks, can they get systemic therapy later on for their cancer? If we do and they end up with a very short residual rectum, are they going to end up really miserable because they have terrible bowel function for the rest of their life after we get them all back together, et cetera, et cetera? if you want a good example of what connected knowledge looks like in your everyday existence, think about driving a car. So when you get in to drive your car to come to work in the morning, as I assume most people do anymore, you get into your car and you drive to work, and your brain accesses the knowledge that says, drive the car. And that's it. Most people show up to work and they can't remember the different color cars they saw on the road. If they saw a friend on the road to work, who pulled into the garage before or after them, because a lot of us show up to work at the same time. They can't remember necessarily everything that was playing on the radio, what the disc jockey's name was. The only thing that they remember is that they got to work safely and that they didn't have trouble with it. They didn't say, now I have to push the gas in order to make the car go. I have to turn the key. It all happened, in the words of Apple Computer, automagically. Your brain accessed that, pulled it forward, and plopped it down and said, all right, drive the car while we think about our patients on the way to work, or we call our spouse, or whatever thing that you do that gets you through your commute. So the way you build connected knowledge is linking known facts and skills to one another. And ultimately, what that results in is the generation of an expert in a field. So we're going to take someone who's a complete novice and an expert. We're going to take the Lego bricks, and then much in the same way, if any of you have ever had young children that have had to build a Lego set with your children, or maybe perhaps you're some sort of giant Star Wars nerd who likes to build Star Wars Lego in their own time, has built a Lego set. Usually the way it goes is like this. You take out one piece and you put it together with another piece and another piece and another piece, and then you have this little chunk. And then you take these other chunks and you stack them on top of each other, and all of a sudden you end up with, the Millennium Falcon or whatever thing you're building. Not that I would do that. But the way you end up with an expert is by starting as a medical student and laying that foundational knowledge so that you can create progressively larger and larger chunks and therefore develop mastery. And once you have these chunks that you've developed, ultimately what you're going to do is try to develop critical thinking. And critical thinking comes from the ability to look at those chunks not just as what they are, but imagine now taking that chunk and treating it like a Rubik's Cube. So you're going to be like, oh, this patient has MRSA pneumonia, not VRE pneumonia, and so I've got to give them this antibiotic, and I got to talk to the pharmacy about how often to dose it, and then and so you're manipulating that chunk in real time in order to produce the desired clinical outcome. So I want to quickly shift gears a little bit, and with that knowledge of kind of the baseline of the way that knowledge works in medicine, I want people to describe to me what it looks like to be a clinical teacher the way you work today. Okay? So I will Alt tab over to my chat and I'll look and see if anybody will answer the question of what it looks like to be a clinical educator in today's world. Frenetic. Oh, it's Dryden. What's up? Flexible, spontaneous. Ooh, I would love to be flexible and spontaneous. Describing my thought process while I'm caring for patients. Okay. Multitasking. Ooh, Socratic. Ooh. I got a whole talk on Socratic method, but we'll hold that for another time, Murph. By the way, Aaron Murphy, you're now called Murph. I just decided that. So that's from now on. Crazy, hurried, rushed person trying to act calm. Right? That's true. Notice that my GI faculty say things like frenetic. Oh my God. Smith says inspiring. Thank you, Clay. That's awesome. That's really great. I echo your sentiment. See, I always knew I could count on Clay Smith for good vibes. So, all right. So if you're anything like me, and apparently like Dr. Kruger and Dr. Dryden, this is what it looks like trying to be a clinical educator anymore. So I'll let you in on a little known secret in terms of just rote data and numbers. In a paper published in 1978, we had approximately 45,000 clinical faculty at medical schools and academic affiliated institutions throughout the United States. Right now, it's up to about 187,000 over the course of the past 42 years. So what made that jump and made a difference, right? Is it the need to educate a greater number of medical students? Is it the need to produce research at a greater pace? Is it the shift toward group and large hospital entity-based care as opposed to private practice? Is it MACRA and MIPS for those of you that follow the billing and coding world and whatnot? It's some of all of that, but like the root of all things, it has significantly to do with finances. So as we've seen more and more complex patients and more patients have been driven to academic medical centers, and academic medical centers have tried hard to keep up with patient demand, they've had to hire more physicians, and they've given those physicians greater impetus, I'll say, to see more patients in a shorter amount of time. And what that's done is that has taken the 24 hours of a workday and greatly expanded the amount of time you need to see a patient and greatly diminished the amount of time that you have to educate the people around you. And so the end result of this is what used to be a very Socratic, very inspiring series of rounds that were made on your patients every day. And they've turned it into almost making medical education an afterthought about what we do every day. I would say that most of the practitioners in every academic medical center around the U.S. wake up and think, well, I've got to get this patient out. I've got to get these cases scheduled. I've got to get rounds through, and XYZ. I've got my administrative duties and et cetera, et cetera. And hopefully somewhere along that laundry list, they give some thought to their education, unless, you're like Brown and Murph. Oh my God, you guys are Murphy Brown. I just decided that too. If you're like Juliana and Aaron, and that's one of your primary assignments, that's going to be what you think about mostly. But the majority of people are thinking about clinical care things. And, it's one of, if people have seen the movie Usual Suspects, it's one of my favorite movies. And they talk about, in the movie, there's a very famous line that says, the greatest trick that the devil ever pulled was convincing the world he didn't exist. And I think that that's a patent lie, because the greatest trick that the devil ever pulled was the electronic medical record and leashing us to it, so that we all spend however much time at night after the kids are in bed with our laptops trying to get caught up with the EMR and not get delayed in our billing and coding and whatnot. And so all of this has led to a combined atmosphere of decreased clinical education. And so look at the question that you wrote, or look at the questions that other people wrote initially, and I want you to think about the purpose of the question that you wrote. Why did you do it? Why did you write the question that you wrote? Or if you didn't, why would you ask the question that you initially asked? For those of you looking at the slides, yes, I am a pen snob, because that's a Pilot G2 in my picture, and yeah, I'm rocking one right now, so yay for pen snobs. I got an agree from Tad Dry, no thank God. So why would you ask the questions that you ask of your learners? You're trying to critical thinking, share their thinking process out loud. Want to know, students think how I can teach in the current working environment to evaluate knowledge. Okay. Assess understanding of content. Okay. So your goal during clinical teaching, hopefully, is to get to here, get to critical thinking. So what is critical thinking, and how does that matter for teaching? So critical thinking is the ability, it's a meta competency. So when we talk about competency-based medical education, that's come down through the ACGME, and all residencies everywhere talk about the 6 core competencies, and you have to have these 6 competencies in order to be considered a good physician. So things like professionalism and medical knowledge and interpersonal interactions and all these things. But critical thinking is the single guidepost that transcends everything else. So if you can think critically about what's going on with your patients and the situations surrounding them, it can be kind of the silver bullet to becoming a better physician. And if that's true, why aren't we all trying to make this the thing that we're doing all the time? And are we really not teaching critical thinking, and how can we do it better? So critical thinking is based on the concept of not showing or demonstrating, because teaching isn't telling, right? It is this is the concept that you have to pull things out of people and not put them in, okay? If a third-year medical student has made it to the wards, they can put stuff into their own head, right? They had to take this massive exam that was probably one of the more traumatic experiences of all of their lives, and they had to wedge a whole bunch of stuff into their head. But how do you use those small Legos, those building blocks, and now pull that information back out in such a way that you can use it to treat a patient? So I love this particular quote from Pooja Agarwal. She's a cognitive scientist and educator, and if you haven't read some of her stuff, it's worth your time, even just to flip through on the weekend. So she says, when we think about learning, we typically focus on getting information into students' heads. What if instead we focus on getting information out of learners' heads? So the way that we do this is through asking better questions, and this is the framework that we're going to use to ask those questions. Many of you may be familiar with something called Bloom's revised taxonomy. So Bloom was a cognitive scientist an educator back in the 50s, who produced this pyramidal structure to the side of the screen here that devised a way to analyze thinking skills in terms of lower order thinking skills to higher order thinking skills along a gradient. And this was originally designed to guide people in the creation of learning objectives for students. And so the idea was that if you can use higher order thinking skills, the questions that you ask designed around higher order thinking skills ultimately will lead to a greater percentage of critical thinking in your clinical questions. So when we look at people in the clinical teaching environment, we want to know, if we're trying to teach critical thinking and we're going to use higher order thinking skills to do it, how often are we asking questions that ask our learners to use higher order thinking skills, or the top part of that Bloom's pyramid? So, this is in the Journal of Nursing. This is just an example because this is not unique to us in medicine. Almost everybody in the health professions educational environment, or HPE, asks questions almost exclusively on a fact-based or low level. So if you think about the majority of the questions we ask every day, and I still to this day, knowing this, can be guilty of this all the time, say, what is the most important structure lateral to the sigmoid colon that we don't want to injure during the course of a sigmoid resection? The ureter, right? And so that's a what question? That's an identify question. That's knowledge, right? Have you read this thing before? Do you know about it, right? What is that large 4-chambered structure in the chest that sends blood all the way around the body, right? And so because the majority of the questions we ask are lower order questions, we're doing a disservice to our learners using what little time we have. So if we're going to only have a short period of time every day to engage them, we need to take those questions and move them away from the bottom of the pyramid and move them toward the top. The truth is, 99% of the people that we're educating now in medical school are always going to have ready access to the bottom of the pyramid, right? It lives in the palm of their hand, and it's produced by either Apple or Google, and they can just look up the answer to the question. And, having foundational knowledge is good to some degree, but teaching them what to do with it is much more important. So the first thing I thought when I saw some of this data was like, that's a nursing journal. Surely as a surgeon we do better, because surgeons have a very high opinion of themselves and a very low opinion of everybody else. And I will deny till the day I die that I said that, but it's true. So here's a surgical journal. It's the same thing. Most of the questions asked during the course of the surgery have very little, if anything, to do with higher order thinking skills. They have to do with, what's the next step of this operation or what have you. And this trend continues on down the line throughout the majority of medical education. So if better questions equal better critical thinking, and better questions also lead to clinical reasoning. Now let's get to the, so act one of a good three-act play. First is you introduce the characters and put them on a mission. Step two, you put them in mortal peril. And step three, they save the day. So step two is now's your chance to be learning about the mission, and I'll put you in mortal peril here in a second. So this is the name of the tool that we've developed here at the university. It's called the card because that's a clever play on words. Also, you can't have a fun educational tool without having a mnemonic of some kind. And so this is the questioning aid for rich real-time discussion. And as soon as we get these back from our latest print run, everyone in the department will have one of these in their pocket so they can refer to it. But basically what this is a method of helping you ask better clinical questions, but trying to turn it into something like driving your car so you don't have to engage your cortex. If you're like me and you're like Beaker these days, you don't have a lot of cortical function to spare, and so we're hoping to take the act of instilling critical thinking and asking better clinical questions and distill it down to something that people can do on the fly without a lot of hard work. So with that being said, we're going to revisit our friend from before, Bloom's taxonomy, and we're going to start by looking at some things on the right-hand side of the screen that talk about Bloom's verbs. So the verb that you use to ask a question oftentimes will pigeonhole it or put it in its appropriate place along Bloom's taxonomy and along your higher order thinking skills. So let's give an example. So if you look at the bottom under remember, I'll use the first one that says define. For those of you that might be watching on a phone, I'll try to narrate the best I can. So define would be like, what is the definition of stroke volume, right? And, that's a knowledge-based question. So I think it's end-diastolic volume minus end-systolic volume or something like that. Okay, you can tell how long it's been since I accessed that stuff. Whereas a higher order question might be, I'll use number 5 just because that looks good right now. And my older son's favorite color is orange. And the first thing in there is influence. And so I would turn to my learner if I wanted to try and think about critical thinking skills or higher order thinking skills, and I would say, what can influence stroke volume? What medications could we give to influence a patient's stroke volume, and how or why? Okay. Or failing that, you say, we have a patient who has poor stroke volume. Defend your choice of medications to treat this patient on the cardiology service, right? Not just tell me why you did it, but defend it. List reasons and defend your clinical reasoning behind that. And by the act of doing that, what you're forcing the learner to do is to think less in terms of, this beta blocker does more X, Y, and Z, but you're forcing them to think in chunks. And by doing that, you are helping them practice that chunk-based thinking so that they will have better clinical reasoning and better critical thinking for the days ahead. So in order to make this even less cortical, because I had to actually use my brain for a split second to create those questions, we came up with some questioning strategies for you so that you can not have to think about this too much. These are what they are. This is going to be in the pocket aid that you'll be getting from the Faculty Development Office, hopefully fairly soon. So things like, all you have to do is pull out your card and flip to one that you like. And I'll give you some examples. It's a little bit difficult doing this virtually because normally if we were in grand rounds, I would hand out everybody a card and we'd kind of work through it. But I'll give you, I've pulled some images out from that And we'll go through it a little bit together here to kind of give you an example of how to ask these questions. So it's 8:36, so I'll try to get through this in time. Just for everybody, if you're curious, I started talking about 8:02 or 8:03, so it's been 34 minutes. So that's 34 divided by 2 is 17. 17 minutes is roughly about the amount of time that anyone can focus on a lecture of any kind. So if you ever watch a TED Talk, there's a reason the TED Talk doesn't go longer than 17 minutes. They have a little red counter at the bottom, and that's because we've studied this. And so if you are giving lectures to someone and you haven't moved on to your next topic or made some sort of significant point and within 17 minutes, you've lost about almost everybody. Within 17 minutes, everyone's looking at their phone or what have you. So every 17 minutes, stop, make a joke, acknowledge something, get back to the point, but realize that twice now people have had to have a breather of some kind, and hopefully we can come back to it. But when you're putting talks together, know that people's educational time span lasts about 17 minutes. Notice I didn't say the time span that they can pay attention, or attention span for movies or anything else like that. People can pay attention to a movie all they want, but educational time span lasts about 17 minutes. So, okay. So next question. In the chat, provide an example of a topic you would need to teach a learner in the near future, perhaps later on today after grand rounds. And I'm going to do my very best, whose line is it anyway, and try to teach internal medicine as someone who hasn't had it in a very long time by using some of these question asking strategies and kind of give you some examples. So I'll flip over to the chat here and let's see. Give me an example of something you'd have to teach about. Critical thinking during a code. Okay, so ACLS situation is good. Hypertension management. Okay. So perfect. I'll go with hypertension management. So let's go on to let's start with that. So this is a complication cascade. So what you would normally see in your little handy dandy card that goes in your pocket is you'd see the thing on the right hand side of your screen. We've color coded the knowledge along the lines of Bloom's taxonomy. We even got real cute as we developed this, namely in order to get to higher order thinking skills or the hot thinking skills, you move from the cool part of the color palette from blue to red because that's a warmer color and that's the higher order thinking skills. See what we did there? But so knowing absolutely nothing about hypertension management other than that I'm on valsartan myself, I'm going to attempt to ask a question about that. So thinking about the potential complications of hypertension, the first thing I would ask is I would turn to my third-year student. I would say, give me a summary of how you diagnose the complications of someone who has poorly controlled hypertension. Okay. Or failing that, you might say, summarize for me the potential complications of people that are on antihypertensive treatment. Or if I wanted to move further up the list, I'd say, let's say that we're going to start administering these certain an antihypertensive to this patient. What are the potential complications that you can predict for that patient given the administration of this treatment? Okay, and predicting is one of the most powerful things that you can ask a learner to do, even though it's kind of in the middle of the taxonomy, simply because that's the beginning of chunking. That's where prediction is one of the most powerful tools that you have to begin to pull things out of people. Okay, next, justify the best approach that you might have to treat these potential complications. So I have not used this in a very long time. The last time I think I used this word out loud is when I was asking Dr. Kruger when I was a fellow about how to get the bowel of peristalsis in endoscopy, and she said, I think you give half an amp of glucagon, and I've learned that and never forgotten it. But let's say someone overdoses on labetalol. Why would you justify the use of glucagon as opposed to some other, anti-beta blocker thing in order to get it to reverse? Okay. Now here's the real kicker. When you really start getting up the higher order thinking skills, You can turn to a learner. Maybe this is more of a resident or a fellow level question, but what you would say is, think as you're a practicing physician and you want to develop a treatment plan to minimize complications for all of your patients on whom you're going to start antihypertensives, right? So now what we're asking to people to do is chunk together the knowledge of what complications can happen, what are the different groups of patients, how do you develop a treatment plan, how can you work within your system, how can you work with the office staff or the hospital staff that are with you. And so now we're spinning the Rubik's Cube. Now we're moving the parts around, right? So we ultimately get a solved Rubik's puzzle. And so you're going to get a much better return for your dollar in terms of the amount of time spent by asking people the questions toward the top of the pyramid as opposed to the bottom, which is not to say that we should abandon the questions in the purple and the blue and the green, because without those questions, you'll never even know what colors go together on the sides of the Rubik's Cube. You can't spin it in order to put the colors together if you don't know that green goes with green and blue goes with blue. So if you're asking a third-year student, describe to me the different types of antihypertensives that there are, that's critical for them to know. They'll never be able to justify the approach to treating the complications, justify their approach to the complications of that particular medication, or justifying their choice of that medication over another if they don't even know what their options are to begin with. So I'm not asking people to say, go when they're making rounds this afternoon and just completely disavow all knowledge of lower order thinking skills, but try to not look like the surgeons do when we're asking intraoperative questions and significantly left shift things on the curve toward things 1 and 2. So I'm going to go to the next thing, which is and this is all examples of these questioning strategies that I'll get to y'all in a PDF at the end of the talk. I'll send it to Juliana and Aaron to distribute. But a microlearning plan is basically asking your learners to identify what they want to learn. And it's an exceptionally powerful tool because it really invites the learner to think about what they're trying to get out of what you're doing that day. This from learning science, we know that when you can personalize and also get at the underlying emotions behind why they're trying to learn what they're trying to learn, that you will significantly increase their retention as well as their investment in their own learning. So with a microlearning plan, you might say, why don't you recap for me your new learning that we learned based on participating in or even just watching this code environment, right? And an appropriate answer to that might be, oh, well, we start off by giving epinephrine and then blah, blah, blah. And it might be, some of the rote answers to what drugs do you give in a code. But it might also be, code environment is pretty crazy. And without some thought and organization, everything looked really messed up and horrible. No one, people were shouting orders and barking out assignments and X, Y, Z, and no one really seemed to be in control, or the converse, which be that, this physician is, knew this patient well, walked in, took control of the situation, and had things well in hand, and has obviously experienced in doing that, and I want to be like them because reasons X, Y, Z. So another example would be, all right, students, you're probably not going to participate in the actual administration of drugs during this ACLS code event. I want you to think about something you don't understand and now rephrase it in a different question. So what you're doing is you're asking them to look at that particular chunk in a different way, right? Is that actually a blue square on the side of the cube, okay? Or is it a green square? Another powerful tool is connection. So I want you to connect being part of this code experience today to your original goal of becoming a doctor. How does this meet up with that goal? Did you get into this to save lives? Did you get in it to ease suffering? Did you get into it because you want to think critically about pharmacology and its interaction with other medications and what? I mean, there's any other number of reasons to become a doctor, and most of us don't learn them all until we get very advanced in our careers. I'm still learning every day why I love this job. You can ask students to reflect on their goals for learning for today. And I would ask them to do this before we even make rounds and say, all right, we're getting ready to go round on some patients upstairs. What do you want to get out of this today? Pick one thing that you're really interested in learning about. They can look at the list and say, I want to know more about CHF in this particular patient because a CHF exacerbation in this patient almost doesn't make sense. And I want to understand how I can, examine that chunk and make it fit in with a larger piece. And if you want to get really, really ambitious, you can say, how are you going to create a plan to practice what we learned today on rounds? How are you going to integrate what we learned today into how you exist as a physician, right? And so by doing this, again, we're getting to the point where we're thinking about our physicianhood, for lack of a better term, in that metacognitive Rubik's Cube type way. So let's see how much time we have left. Not much, 13 minutes. So with those 13 minutes, I am going to ask anybody that's still paying attention to try not necessarily using the thing on the right-hand side of the screen, but just look at the Bloom's verbs over here on the left and try to, make a question about something you'll teach today using a verb from levels 4, 5, or 6. Elaborate, assess, diagram, inspect. Just try to ask a question and type it in the chat that has nothing to do with remembering or understanding. Apply is okay because that's necessary, but just to try it out, type a question in the chat that uses Bloom's taxonomy levels 4, 5, and 6. Now, I'm going to give everybody a major caveat to this, which is that, number one, when you go to do this, it is going to feel very hard and it's going to feel very strange as the question asker. It still feels very hard for me because I've made this, try to make this a significant point of my teaching, and this is something I'm actively working on in an area of academic interest and everything else like that. But still, I find it very hard because it's not the way I was taught. Secondarily, your learners are going to look at you like you have grown both a second and third head, because these are not the questions they're used to getting asked, right? They're used to questions that they take on UWorld or USMLE prep, and they're not being asked to think about medicine in this way. And so be fully aware that you're going to have to allow significant time for both yourself and the learner when you do this in order to get comfortable. The other expectation in addition to that is you have to expect failure both on your part and the part of your learner, and you have to encourage it, okay? So some of you may have heard the mnemonic before. Fail means first attempt in learning, okay? So you are going to fail at this. I do every day. So do the students. So do the residents. And that's to be expected, okay? But every time you fail, when you try to engage this thinking, this critical thinking, questioning kind of role and model, what you're doing is you're building those bridges. You're engaging the act of the connections that we talked about. You're building the larger brick in order to be able to pull it out and access it and then ultimately fit it into the cube and spin it around. And for those of you that are playing our home game, I have had enough mixed metaphors today for a lifetime. So please feel free to give me a bunch of hard time about that. Elaborate on the relative benefits of biological therapy for Crohn's disease versus conventional therapy and defend your reasoning. Dryden gets the A for the day. I'm not at all surprised. Chris Kruger, propose an alternative treatment plan for a patient with hypertension. Juliana, defend your empiric antibiotic choices for this condition. Ooh, I like that. I like these guys. These are good. Shout out to PBL, compare and contrast operative versus non-operative treatment for an ACL tear. Ooh, that's awesome. Professor Cook, what does she got to say? Generate a plan for treating the patient's hypertension and justify your decision. Right, perfect. So generating a plan in and of itself depending upon the nature of the situation, may be a lower order thinking skill, but you have to hold them to a higher order thinking skill. And it was Jen's addition of the second question of justifying your decision that automatically kicked it up into now we're chunking again. So that's awesome. Strong work, everybody. It's very good. Okay. I'm going to skip ahead because we're a little bit running low on time. Some questions are considered not necessarily on Bloom's taxonomy, but what we call elaboration questions. So how does the underlying pathophysiology of whatever thing explain the clinical signs and symptoms we see in this patient? So the purpose of how, why, and what questions in this situation are to ask much more open-ended questions that are trying to stimulate that chunking as well. So it's, you wouldn't want to ask, why does the blood flow in the direction that it does? Although that's a probably really good question I don't know the answer to. You probably would say something much more like, why do patients with hypertension develop heart failure, right? I mean, that's there's some basic knowledge to that, but it's also some higher order thinking skills as well. So the purpose of a how question, a why question, or a what if question would be trying to ask an open-ended question and to generate some of those chunks and try to improve that critical thinking in a way that makes people stop and really ponder what they're doing as opposed to just blindly clicking through the EMR in order to get the correct medication on board. So I put up the key at the end of a lot of talks, and I directly stole this from my good friend and actually one of my best friends and colleague in the faculty development world, Stacy Sainer. If you guys don't know her, she's pretty amazing. She works in the faculty development office here on the HSC campus. She's all about making better teachers, and any sort of success or abilities I've had in the clinical teaching environment is directly a result of my relationship with her. So she would ask the question at this point of the talk, which is what, so what, now what? So what is better clinical thinking and critical reasoning through better clinical questions? So what? Hopefully you have an answer for that, but so you can ask better questions of your learners and engage them in better critical thinking. And so if that's so what, the now what means, hopefully once I can get you all the PDF of this document that you can either have on your phone or even just refer to every now and then, we can start asking better questions of our learners on rounds even as early as this afternoon and this morning. So that being said, I'm going to give a shout out to everybody in the faculty development office. So we're always trying to make better teachers here at the University of Louisville. You can drop by what we call the faculty feed, which is all about better teaching skills. We have new articles every month. We have a lot of content on there for people that want to be better educators and better doctors, at least in terms of the Proto-French version of the word. And with that, I'll stop sharing my screen and I'll be happy to take any questions.
So Russ, I'm going to say something. When you showed that picture of the key and it looked like it was in a petri dish, I was going to ask you if you had stolen that out of a patient that you had scoped.
No. So that was anymore when you use PowerPoint, it says, do you want the ideas to make this slide look better? And you click on one of them, and that's the one I picked.
Well, I think a key for us though is you actually kept this audience involving the chat. You know, we all wanted to get involved, and you also taught us. I really do think you succeeded in teaching us how to be better teachers. I had no idea what Bloom's was, and I probably asked very many more, simple, lower order thinking questions. So I really want to say thank you extremely for teaching me something today. I really, really appreciate that.
Yes, ma'am. Absolute pleasure.
I see if it'll let me.
Don't forget forget to unmute, folks, if you want to ask questions. I know sometimes our technical processes were kind of auto-muted by the program, and so you have to unmute if you want to ask Russ a question in the last couple of minutes here. Russ, you're getting kudos on chat if you've seen them. Everybody's giving you some.
Yay, thank you. I'm trying to hunt up my document here so that way I can get a copy of this. Usually what I do is I keep it as like a PDF on my phone, and that way I can pull it out and refer to it. But we actually have a working tech demo that we're about to have an app for your phone that you can just hit a little button and it'll generate the clinical questions for you, so you don't even have to think about how to ask them. You just hit the button and it says, all right, insert your diagnosis here, and here's a great clinical question. So. Okay. Well, thanks so much, everybody. I'm going to head out to I think we've only got like 25 or 26 in the office today, so it's a slow day. So I'm going to head off to that. Thanks so much for listening, everybody, and I really do appreciate it.
Thank
Thanks,
you,
Dr.
thank
Kruger.
you,
Thanks,
thank you.
Jen.
Yeah, thank you, Dr.
Bye.
Farmer.
Thanks,
We appreciate it.
Thanks, Aaron. Bye.
Thank you, Dr. Farmer. Thank you, Dr. Kruger. All right, I think we're done. So long, everybody.